a very common thing that we end up doing for the actual exam itself is we fill the space of time with waffle. We end up saying stuff that we know can't really get us into too much trouble, but also we're not getting to the point. You'll find that 5 minutes flies by once you start doing your preparation. Now, knowledge is something that you either have or you don't, but the style of your answers is something that you can prepare. And actually, I would suggest that you probably start looking at this around ST3 and 4 and just start getting used to conveying your knowledge. We're all grown people, and outside of the world of surgery, we have mortgages or rent or children or other responsibilities, and we're functioning members of society. And yet when we get into surgical training and when we're in the context of work, we end up almost infantilizing ourselves and waiting for the boss to tell us what's next and not having the confidence to, I suppose, convey what we want to say. So the purpose of this particular section of slides really is to get you to think about how you answer things and how you focus on different elements of your own answering, and we'll go through some simple examples of these things as well, and also little things that you can work on just for your preparation of your answers. So the first part of all of this then would be the preparation of your answering style. It really takes time, and I've said here that it might possibly take years. It's something that you can actually work on quite a lot, just even day to day in clinic. See what works, see how it works for you. Do you want to be somebody who's a little bit adversarial when it comes to your answers? Do you want to be somebody who's a little bit more submissive in your kind of laying out of answers? But also you have to find your own style. In our deanery in South Wales, we have Friday teaching, and then generally the people who are further along in their exam preparation will be asked questions at the front. That doesn't mean that those at the back can't listen and can't prepare what they're doing, and I would suggest to my colleagues that you listen to what the guys at the front are doing, and also start thinking about what your colleagues who maybe are non-trainees who are preparing for the FRCS as well, see how he or she would be preparing for their exam and what type of answers they're giving. It doesn't mean they're right or wrong, it just means that their style may or may not suit you, and you can pick little snippets of different parts that suit you, and you can make a patchwork effort out of all of this then. What do you like, what don't you like, and also what sounds good to you. So in this part here, what I've said is that predictable questions give you predictable answers. So what I mean by this is we have a base curriculum that we can work on. So for instance, if it's a trauma case, you know that you should be saying that you've covered ATLS principles, you've ruled in or out an open element to the fracture, and then if there are any BOSE guidelines that are appropriate, be it for mass hemorrhage, be it for polytrauma, burns, plastics, orthoplastics, open fractures, supracondylar management in children and whatnot. The general management of injury and pathology is something that you want to lay out early on in your answer. You are not getting many points for this, but if you don't answer it and you don't say it, the examiners can't assume that you've said this. So what I've said here is that you can break things down in nice signposting for the examiners. So you could say something like, I would manage this in one of two ways, be it operative or non-operative. And then you've just given a very nice kind of categorization. It's quite obvious. I mean, it's what you do day to day, but you're showing them that you have a way of thinking about these things in nice categories. If it's something, let's say, around the hand or the wrist, you can talk about joint preserving, joint replacing, or arthrodesis type procedures. And again, you haven't committed, but you're again signposting so that the examiners can tell this candidate has a nice logical schematic that they're following, and we can follow it along with them. If it's, let's say, trauma, you want to do it in a staged versus single sitting, it might be something that you want to span and scan, or it might be something that you want to definitively fix there and then. Also, if it's a revision case, you want to talk about single stage, two stage in a single sitting, or two stage with prolonged IV antibiotics. The other way that you can talk about them being emergent versus urgent versus delayed or even watchful neglect. And these are also very common things that you do day to day. You just want to convey this to the examiners and say, I know what I'm talking about, just follow me through the answer that I'm about to give you. So for instance, if we move on to the context as well, it's something that's really, you hear people babble on and what they're saying isn't exactly incorrect, but it's contextually irrelevant. So for instance, if somebody's in the emergency department in the viva that they've given you on that topic, well, you're not going to be talking about elective clinic special tests. But equally so, If you're in the fracture clinic, ATLS guidelines isn't something that you're going to start talking about. And if they're in an elective clinic, you're then also not going to be looking for, let's say, pathognomonic signs on the x-rays that would be only related to acute fractures. Don't say things that are irrelevant, and also make sure that you kind of keep your mind and your context in mind as well. So ligamentous testing, let's say, around the knee on a polytrauma case is not something you're going to be focusing on. You wouldn't be doing a Lachman's or an anterior or posterior drawer test on a tibial plateau fracture in the trauma bay. But yet you will hear people go on to autopilot and mention things like this when they're preparing for the exam. So just be conscious of what you're saying and condense it. Age-specific tests as well might be more relevant for children. Degenerative tests, instability stuff in a rotator cuff deficient degenerative shoulder is not relevant, whilst rotator cuff deficiency in what you think is an unstable but intact shoulder, again, it's not relevant. If somebody doesn't have biceps tendinopathy, there's no point in focusing on the biceps special tests if the history they've given you is all instability. So just keep the context in mind as well. This is just a little rundown of ATLS principles, the way you'd outline them. So the two of these paragraphs have very close, let's say, amounts of information in them, but the way that they're coming across, I would hope to think, are a little bit more succinct and a bit clearer. I would manage this patient following ATLS principles and C, A, B, C, D, E. I would examine their chest for X, Y, Z. I would examine their pelvis for 1, 2, 3. I would then assess their neurological status and document this on an AJA chart. You're literally just describing to the examiners what you would do bit by bit, but you've wasted 30 seconds of vital point gaining time. Excuse me. However, if you were to say something along the lines of, I would manage this patient as part of a trauma team in the emergency department following ATLS guidelines. Provided there are no life-threatening or more pressing injuries, I would manage this injury following the Bose principles for, let's say, open fractures. And this would be, let's say, related to the picture they've given you. So they may have given you a mid-shaft tibial fracture with an AP and a lateral radiograph and a history of a high velocity road traffic collision from a motorcycle. You haven't really skipped any of the ATLS stuff. If they want you to be directed back into other associated ones, they can bring you back to it. But you haven't skipped stuff. You've touched on ATLS. You've mentioned that you're in the emergency department, and you've mentioned that a trauma call or a trauma team involvement would be there. You just want to condense it. And by the end of this, you've already gotten to the Bose principles in 4 lines. You haven't focused on, I would check for crepitus, I would check for guarding, I would check for rebound tenderness and these types of things, because they're not necessarily what you're looking for. You are looking for them in real life, but in the exam, you've got 5 minutes to get your information across. Fracture management in the ED is also something that I think is just money for jam. It's very simple point scoring, but also very easy to miss this, let's say, the available marks. Any fracture that you manage on a day-to-day basis, you get an x-ray, or it's been done for you and it's been referred to you. Your next step is immobilization and or analgesia. You'll reduce it if necessary, and if it's a dislocation, you'll reduce it. Appropriate documentation of the neurovascular status pre and post intervention with appropriate analgesia, bearing their allergies in mind. I would then re-image the affected limb, the affected joint, or what's relevant, and then I would plan for, and then it depends on what the injury is, for either acute admission or delayed care in an appropriate clinic with specialist input, fracture clinic, or let's say a hot knee clinic if it is ACL type stuff. So what I'm getting at is you want to practice these types of comments, these types of little 3, 4, 5 point answers, and that stuff there is perfectly relevant and transferable to every fracture case you would be given. You might change it a little bit here and there, but the structure's the same. Image, immobilize, reduce, re-image, admit. And that's your run. And you want to be that confident, that nice bit of rhythm going through your answers. And then the examiners are kind of put at ease and they'll say, this candidate knows what he or she is talking about. Let's move through the topic and let's give them a chance to score more points. For example, on these things, you might be saying, this is a plain radiograph of an AP and a lateral view of, let's say, a knee. There is a fracture of the proximal tibia involving the tibial plateau and an intra-articular extension, for example. Some of the phrases that I started using myself during my exam preparation were, I would manage this firstly with basic first aid by way of analgesia, immobilization, and documentation of neuromuscular status, skin integrity, and associated injuries. Once immobilized, repeat imaging with orthogonal views of the injured area and the joint above and below if relevant. If reduction is necessary, then you start talking about what you're doing with your colleagues in ED. Adequate sedation or analgesia by an appropriate airway trained colleague, either with IV, inhalational, oral, or injected, let's say, hematoma block, analgesia, and then reduce the fracture dislocation and repeat the imaging or arrange further imaging. I would then repeat my examination, document my findings, and then move on to assess their neurovascular status and any deterioration or resolution of previous deficits. So, for instance, shoulder dislocation is a gimme. They might say they've got a neuropraxia of their axillary nerve, but you have to talk about that before you do the reduction, because then they would say, well, how do you know that you didn't cause it with your traction? So again, these are things that are very simple. You do them day to day, but remember, if you don't say it, it's not heard. And if they don't hear it, they can't give you the marks for the points you're making. Elective patients in clinic then, totally different kettle of fish. But again, you can break this down into a nice structured fashion. This is a plain radiograph of XYZ. It's an AP and a lateral view. This is a weight bearing or a non-weight bearing or a specific stress view. I can see there is. None of this there appears to be. I can see there is XYZ, a fracture, a dislocation, a subluxation, or persistent deformity following intervention if you have a series of x-rays. You then want to know what the history is that led to this, and you want to kind of get this across and highlight that you're asking the pertinent questions. What led to the imaging being arranged, and who arranged it? Was this arranged in a specialist clinic or in the community by their GP? What is the presenting or primary complaint of the patient? Previous interventions they've had, for instance, arthroscopic interventions, intra-articular injections, corticosteroids, any form of lubricants, anything else like that. What's their current level of function? Are we talking about a high level, high functioning athlete? Are we talking about somebody who's a bit more sedentary? And what is the issue? And also, you can also touch on the more holistic side, which shows that you're doing a more patient-centered approach with what are their wishes and expectations and what does the patient want from us. You haven't committed to anything with any of that. You're keeping it nice and broad, but you're also focusing in on showing that you're aware of the pertinent questions. Any patient-centered and patient-involved approach will always be preferred. And also then you want to talk about, let's say, concerning features. So for instance, if somebody's referred you for consideration of a total knee replacement in a patient, you want to know about coronal and sagittal deformity, varus valgus, fixed flexion deformity, PFJ arthritis, and also the ligamentous integrity. So for instance, if the patient has a very valgus deformed knee with a fixed flexion and PFJ arthritis, you're already touching on the fact that you'll need more of a distal cut. You probably won't need to do much of a medial release, but definitely will need to do a lateral release. You'll probably do a patellar femoral resurfacing and do a patellar button because the PFJ is involved. And also you'll be aware that the MCL is not as functioning as what you were hoping before, and you may have a lower threshold for doing a PS or a more constrained type of knee. You've already touched on those in 4 little lines, and you can say, I see that this and this are there, so therefore because of the valgus, the FFD and the PFJ involvement, I would be considering a PS knee with a patellar button. You've already touched on all of this, but you haven't really gone into too much detail and laboured the point, and they can expand on it as they wish. Let's say if you're talking about a hip and they've got a pseudoacetabulum from chronic DDH, then what you might be talking about is, I'm aware that they're shortened. I will try to bring the femoral center of rotation down, but in doing so, I might stretch the sciatic nerve. It shows higher order thinking, and it also means that you're thinking, I may need a femoral shortening osteotomy, which means that my weight-bearing status afterwards may be different. It also means I've got an increased wound length and also an increased risk of infection because of this. You're just highlighting your higher order thinking to make sure that you're conveying to them, look, I'm not a 5 or 6 candidate, I'm a 6 to 7 to 8 candidate for these questions. Basic sciences, again, you'll find loads of stuff online for these where you can define the implant, the material, the condition or the principle, state its uses and contraindications, describe the composition and the manufacturing methods and the generations of them, like bone cement. Also then describe its concerning features. What's good about it? What's bad about it? When would you definitely use it, if relevant? When would you absolutely not use it? So, for instance, rotator cuff deficient shoulder without a very functioning subscap. You are not doing a hemi and you are not doing a total. You're doing a reverse because of the deficient rotator cuff. Then that brings you into the conversation about the reverse polarity, reverse total shoulder, and what are the general geometric and biomechanical concepts of it. Pivotal points of discussion are predictable for materials. So, for instance, why are nails made of titanium and not stainless steel? Why is the femoral implant for an Exeter made of stainless steel and not cobalt chrome and not titanium? Why is polyethylene now impregnated with vitamin E, and why is it ultra high molecular weight cross-linked on one side and not on the other between a hip and a knee? So you want to talk about these, and they're predictable questions. If a poly comes up, you know exactly what the questions are going to be. So for instance, bone cement, give them a definition. It's a biomaterial, polymer and monomer, creates a paste, and it sets with an exothermic reaction. The composition, the uses, the contraindications to use, allergy to cement, but peanut oil, which is in it, is not actually one of them, oddly enough, and special features. So for instance, something that I learned during my training was that cement and cement revisions repolymerize at the cement-cement interface. So if you do then get a peri-implant fracture later on, that will be at the bone cement interval or interface rather, and not at the new cement-cement interface. Again, if you're being asked these questions, you're doing incredibly well. Polished taper slip femoral stem. Again, composition, the uses, cement version only. So interestingly, in the 70s, there was a matte finish. And again, because of this increased friction at the surface area, it didn't allow it to slip. You didn't get the hoop stresses, and it increased the forces at the distal end without the calcar, and they had more peri-implant fractures. So again, they crossed over two theories or two principles, and they didn't work. What are the main alternatives? Well, it's a composite beam femoral implant, and then you want to talk about the differences, what's good, what's bad, what are the concepts between them. Kohler's disease of the foot, for instance, in pediatrics, you want to be able to reel this out. Idiopathic, self-limiting avascular necrosis of the navicular. More common in males and females with a 4:1 ratio, mostly common in 4 to 7-year-olds, and bilaterally in 1 in 4. So there's 4, 4, 4. 4 times the male to female, normally from 4 upwards, and also 1 in 4 will have it bilaterally. Pathophysiology, not very clear, but some suspicion that because it's the last bone to ossify, then they say that because of the other changes and stresses around it with the ossification of adjacent bones, the navicular takes more of a hammering, and then you end up with avascular necrosis of the navicular. It's self-limiting, generally doesn't need surgery, only needs watchful neglect with NSAIDs intermittently, immobilization in some units, and ultimately reassurance for the child and the parents, and all will be fine. There are no long-lasting effects to this. So in total, what we're getting at is that we don't want you focusing too much on the nitty-gritty of little things. I want you to learn the bare minimum that you can then apply to the maximum. So what I would suggest is start looking at your answering style now. Start looking at your wording, your vocabulary, and what works for you, and little structures that you can put in place, because what you are going to get on the day of the exam is something you haven't prepared. But go back to base principles, go back to the basic sciences, go back to your primary knowledge of elective or trauma orthopedics, and you can actually build up a very clear and structured answer that might actually suggest that you've been ahead of the game already and you know what's going on.